Good afternoon, and thank you for being here at today's PHSA's Return to the Workplace virtual conference. My name is Patricia Clausen, the Director of Prevention, Engagement, and Retention for the government, municipal, and education sectors at PHSA. I am pleased to welcome you to this session, First Responders and COVID-19, the Designated Officer's Role, with Tim Metcalf. Before we begin, I want to mention that there will be an opportunity to answer a few questions following the presentation. So please feel free to enter any questions into the chat, and we will select a few questions to ask as time permits. With the realities of COVID-19, the role of designated officer within each emergency services has increased. We are pleased to invite Tim Metcalf to discuss the impact this emerging hazard poses to operations and support division activities, as well as the support provided from local public health units and other governmental and non-governmental agencies. Tim brings over 35 years of experience in the ambulance and fire services, specializing in occupational health and safety and infection prevention and control. Tim is currently a health and safety consultant for Public Services Health and Safety Association in the public safety sector. He is a Canadian registered safety professional and received the Queen's Diamond Jubilee Medal in 2013 for his involvement in occupational health and safety for emergency service workers. Welcome, Tim.
Thank you very much. So we'll be discussing the role of the designated officer. The designated officer is a position within the emergency services, police, fire, EMS. The whole idea, it was a initiative from the Ministry of Health to create a central contact person for when they're dealing with situations of an infectious disease exposure that could have happened to an emergency services worker. As I said earlier, 1994, it's been around for quite a while, but with the emergence of COVID-19, the importance of having this role filled by somebody just is brought to the forefront. So what we'll be doing over the next half hour is discussing the responsibility of the individual, who they be making contact with, and the procedures and policies within your organization that you need to establish in order to support them, and therefore they can then support the workforce. So we're going to speak about the history of the designated officer role. As I said, it was started in 1994, required back in 94. And if you think back to earlier, perhaps the 70s, at that point, a lot of the communicable diseases had sort of been, well, they've been taken care of through either immunization or antibiotics. As a result, there was not a significant exposure. And when I started on ambulance back in the early to mid 80s, there were wearing gloves to a call was not common. There weren't boxes of gloves to wear, gowns, glasses, masks. Exposure just sort of happened, but things were well managed. The 1980s, we ended up with HIV, the emergence of HIV, hepatitis B, hepatitis C. Since then, we've had a whole host of other things. SARS in 2003, we've had Zika, we've had the Ebola outbreak, we've had the reemergence of measles and mumps, and now we're into COVID. So a lot of things sort of started to come back as far as the infectious disease, the excessive infectious diseases. So as a result, the ministry sort of set out this role for emergency services to have a person that is that contact. So the whole idea is they are the representative of the emergency service to investigate any reports of exposures to communicable disease, and they can also liaison with the local public health unit. And when it comes to infectious diseases in Ontario, the public health unit really is that linchpin organization. It's a significant part of their role in Ontario is to take care of infectious disease exposures. So it's those are the people we're going to be making contact with when we're working as a designated officer. They're also responsible for investigating all exposures, incidents, using evidence-based information, and also at the same time interviewing the people with that possible exposure that took place. Now, when we talk about an exposure, we'll just speak quickly about the chain of transmission and how we ended up uh, disease is an old term, 100 plus years old, it broken down into now talking about bacteria or viruses, fungus, prions, parasites. So it's in an individual or in an area, contaminated water, whatever it happens to be. Is so that would be the reservoir, and then it leaves that area in some manner. If it's leaving a person, it would be through bleeding or a cut in the skin, or if it's a respiratory, they'd be coughing it, and it travels through the air, or it lands on something and makes contact. It could be droplet transmission, so it's that sort of 2 meter circle around an individual where there's an increased chance of transmission, or airborne. Fortunately, there's very few airborne things, but airborne is measles, chickenpox, and tuberculosis. So that would be very close, or in an environment where it kind of hangs in the air for a period of time. So it travels in some way, and then there has to be a portal of entry, a way in. So if it's an individual for droplet or airborne, they could inhale it. It could be ingested through the gastrointestinal. It could be breaks in the skin, and it ends up getting into the person that way. And then the individual has to be susceptible. So we have a susceptible host at that point. So they don't have immunization, or their immune system is compromised, however that presents. But this is how diseases travel from person to person. So we've got that infectious agent, whatever it is, and we can use COVID-19 as an example, and it's going to be in the lungs, and the person coughs or excretes it, saliva, bodily fluids, and then it could be through contact or through droplet. If it's in the air, droplet contact. If an individual is touching a contaminated surface, and then the touching their eyes, their mouth, their nose, that sort of thing, into the mucous membranes, uh, a route into the individual. And the way we prevent people from contracting diseases is through PPE. We do that at the portal of entry. We're covering up all those portals of entry, or immunization. And with COVID-19, we're not at an immunization point. But when we think about viruses, and we'll speak about the virus specifically and not about the others, they're small, very, very small, and single cell organisms. And the unique thing about a virus is it is completely dependent upon its host. Viruses do not reproduce on their own. Bacteria reproduce on their own. They have a happy place to live, and they just, when they reach a significant mass, they split in half, and they live their own life. A virus is different. A virus has to find a susceptible host that it then goes into, and then reproduces itself. Well, it's the cells within the host that are actually reproducing the virus. And that's why if I get a cold, bring it home to my family. My family all gets the cold, but the family dog doesn't get the cold. It's because viruses are very specific to species. And when a virus jumps from one species to another, that's when we can get into some interesting situations. And that's where we are right now. Novel. It's never been in humans that we're aware of, and therefore there's a lot that we don't understand about the COVID-19. So, as far as the employer's responsibilities, ensuring that routine practices are done routinely within your organization, ensuring of course, your health and safety systems also in place, um, and then putting in engineering controls and education, PPE, the use of, when to use it, proper supervision. All of these pieces are part of your infection prevention and control program, and very much a responsibility of the employer. Now, the Ontario Public Health Standards sort of set out what the each individual health unit, their responsibilities are, and it's laid out. The most recent copy came out in 2018, and it requires that every public health unit to ensure they have 24/7 availability to receive reports with regards to Mandatory Blood Testing Act exposures that have happened to workers in the emergency services world. So this is their role. It's part of their expected practice. So once you have a designated officer in your organization, that person really needs to reach out to the public health unit and discuss with them, who they are, what we do, how you're to best get a hold of me when you need to, because the communication can flow both ways. Sometimes the worker reports to the designated officer, and then you would uh, receive help from the public health unit. But sometimes public health hears about things, and they need to know who to contact at that emergency service, and then the designated officer would contact the worker. So it does flow both ways. So the infectious disease protocol in 2018, it requires that boards of health, so our public health units, um, possible exposure of an emergency services worker will be assessed, and they will respond to any requests or concerns no later than 48 hours after that request. And they'll also look into the exposure of the worker, and and contact the emergency service if the health unit requires identified designated officer for an emergency. They'll also seek out contact of cases of infectious diseases of public health importance. So they do monitor what's going on in the community, and they're notified if somebody becomes positive of a communicable disease of that individual in their community. So if somebody became positive for tuberculosis in a community, public health is told about that. And then public health will do what's called contact tracing, and quite possibly they'll be informing the designated officer of the possibility of an exposure that might have taken place. They'll be saying, oh, well, that person got to the hospital via an ambulance, and perhaps a fire crew was also there. So they'll contact the designated officer from the ambulance as well as the fire crew. And then they'll also direct any specific action that will be taken for the exposure of that worker, and up to and including post-exposure prophylaxis, which would be medication to prevent somebody from becoming sick, basically somebody contracting whatever the infectious disease was. So the designated officer reports to the public health unit. She'll contact the health facilities and other persons to obtain additional information. So they'll back up the designated officer in contacting the hospital to find out additional information about a sick person, a sick patient they might have dealt with. They'll inform the designated officer of any actions to be taken, and the risks to the worker, and of course follow up with them afterwards. So the public health unit really is your best friend when you're working as a designated officer, and having a close relationship with them is important. PSHSA has offered a designated officer program for many years, and a trend that I'm starting to see is public health units are nurses, infectious disease nurses within the public health units are showing up at those courses to meet all the different designated officers and make contact. They swap cards, they have lunch together, and that way they're starting to develop that close relationship. So it's actually an um, excellent trend that I'm seeing out there. Here I'm just sort of showing you quickly the type of things that you could be notified as a designated officer. Uh, the type of exposures, and on the left side of the screen you'll see a public health nurse notification, and on the right side it would be an exposure that would you be notified by an emergency services worker. So things like group A strep, or infectious group A strep. This could be like flesh-eating disease is one of the ways it manifests itself, strep throat and other ways. But there is, that is in the community, and is a significant concern. Meningitis, tuberculosis, pertussis, which is whooping cough, and then measles, which is starting to see a resurgence, and actually right now in Africa, Madagascar, up through Congo, significant cases and tens of thousands of deaths as a result of meningitis. So it is back as a result of people not immunizing. Um, so so those sort of cases can be a result of somebody going to ending up at the hospital. being tested and they find out that they have one of these particular, then these are just a number of examples. So they have one of these um, diseases, and then they then will contact public health. There's a requirement that a physician, and as soon as the test comes back positive for anything on the what's called the reportables list. And what do you have to do if you have a patient that comes up positive with something on the reportables list? You report it and you report it back to public health. And they would then initiate contact tracing to try and stop the spread of it in the community. And that's a big part of their role. So that's when you would be getting, as a designated officer, a call from the public health unit. And then the other side is when you get a call from your crew members, whether it be a police officer, a firefighter, a paramedic, who contacts you as the designated officer and says, "Oh, I've got a blood exposure, I've had a bodily fluid exposure, a needle stick," any of that sort of thing, or the patient has volunteered to say that they are positive, uh, they have tuberculosis, meningitis, that sort of thing. So those are kind of different ways that you would find out about a potential exposure that your crew members would have. Now, COVID-19 is one of those exposures, and it is on the reportables list now. So you could hear from public health about that as well. So as far as reporting exposures from the worker's standpoint, um, so the emergency services worker has a possible exposure. They immediately report it to their designated officer, and however that looks in your organization will be specific to your organization. Um, some departments run the entire province, and some are very, very small. So however that works for you. Then you've got the risk assessment that is performed and make the determination as to whether there was a significant exposure or not a significant exposure. And if there's a significant exposure, then the worker needs to be assessed at an emergency department is the best idea. Um, even if there's an uncertainty, I'm not sure if you had a significant exposure or not. Let's go to the emergency department and just sort of take any question out of that. So um, another thing to mention here is the incubation period, because if somebody's had an exposure to an infectious disease agent, we often run to things we understand, which especially in the fire world, that might be hazardous materials, and if somebody has a chemical on their gear, then they could be exposing everybody they're nearby, that is nearby them. Um, when it comes to an infectious disease agent, it takes a certain period of time before, while that agent is growing inside, whether it's a bacteria or virus, where it's growing inside you before you start excreting it, before you start giving it off. So while that during that growth period, um, people are normally are not what's called shedding. You're not giving off the virus. Therefore, you aren't potentially making other people around you sick. When we talk about COVID-19, 95%, as the research is currently saying, 95% of people who have an exposure um, will convert to positive or be sick within a 5-day period. Um, and then if you want to move that up to 97%, now you're into 10 days and around there. And then 14 days is everybody will have gotten sick if they were. But there are people who possibly are giving off the virus, but don't have symptoms. And that is actually very unique when it comes to infectious disease things. There are very few things. Influenza, chickenpox, and now possibly COVID-19 are on that list, which is unique for infectious disease. And when we say positive, possibly. You might be saying, well, how is it we don't know about this? It's because this is new. This is something that has not been in people that we've been researching for. If you think about measles, we've known about measles in people's bodies for over 100 years. I mean, it's a very studied disease, and we've sort of seen how it always progresses and what comes out of it. This is all new, so everybody's trying to figure things out right now, and that's why things change as we learn more. So let's just talk about high risk exposure. So any sort of high risk exposure, not just COVID. This could be tuberculosis, it could be meningitis, it could be um, hepatitis A. For instance, the community I live in, um, there's actually been an outbreak of hepatitis A in the community, as well as tuberculosis, and something to think about. We've very focused on COVID-19, but all of the other things are still out there. But the whole social isolation, we're not seeing as many people, so there aren't the same exposures. But when 911 calls and we send our emergency responders to take care of the people's needs, uh, that's when potential exposures can happen. So our high risk exposure occurs when a worker has an exposure to a communicable disease that may be life threatening and has a portal of entry into a susceptible person. So those are the required things to happen from it for it to transmit an infectious disease from our patient or our client, however we want to express it, to our worker. All right. So they have to have an exposure of some sort. It has to be communicable disease, life threatening, way into our worker, and they have to be susceptible. So if you think about hepatitis B, somebody could spit in the eye of one of our workers. The one thing of the bloodborne you have to worry about for spitting in the eye is hepatitis B. So they might have had an exposure from somebody. It is a communicable disease. It is life threatening. It did have a way in if the person wasn't wearing glasses, but they're not susceptible because hopefully all our emergency services workers have hepatitis B immunization. Therefore, they're not susceptible. And as soon as it enters their body, their immune system attacks it, and that's sort of the end of it. So we've talked about our public health unit and its role in surveillance in the community. It's a very important role, and these infectious disease nurses are good friends of the designated officer and the emergency services people, and it is a big part of their responsibility to provide support for those workers. So make contact with them. As far as just quickly, we're going to speak about cleaning, disinfecting, and sterilizing. Just looking at the different levels. So when we're talking about cleaning, that's often expressed as like hotel cleaning. It's just like a soap and water, mild disinfectant, that sort of thing can be used. Non-critical items. When we're into low-level disinfecting, semi-critical is into higher levels of disinfecting. So this would be oropharyngeal airways, things that we would be inserting, but not deeply into the body. A non-critical item would be like a blood pressure cuff or handcuffs, that sort of thing, something that is on the outside of an individual. Semi-critical is entering in, so that would probably be like a bag valve mask, an oropharyngeal airway, that sort of thing, pocket mask. And then critical items which need to be sterilized. This would be a paramedic starting an IV, um, where you're actually putting a needle into the skin and running IV fluids through it through the tube that you're going to be putting into the person. So when we're cleaning up spills, of course, wearing protective equipment, wiping the area, and then you can disinfect the area or kill most of the microorganisms using a 10-to-1 mixture of chlorine, bleach, or water, or accelerated hydrogen peroxide is another way of cleaning an area that has had a potential blood exposure. When it comes to cleaning clothing, all you really need to do is launder. For most things, I mean, if it could be considered a biohazard if you can wring out the blood, but if you wring it and blood doesn't come squirching out, or there's body parts in it, that sort of thing, general laundering takes away pretty much everything. The soap loosens and the water rinses it away, and that's what hospitals use primarily for their cleaning of beds and sheets and blankets and all of that sort of thing. Now, as far as designated officers' resources, I'm sure you've heard throughout the day, there's lots of things on the internet, lots of interesting information being provided by people. Stick to the main sources, though. Uh, Public Health Ontario. Well, I'm going to hit them right now. So let's talk about those. The Ontario Association of Designated Officers was created by Alexis Silverman and another group of like minded individuals back in 2013. Um, the whole idea was to bring together people that are in that. Um, pre-hospital care, primarily environment, that are dealing with their workers having exposures to infectious disease and having once a year conference, having a website with resources, and then if people had questions, they could send in their questions. Uh, for instance, who has a bloodborne exposure form? Anybody have one of those? Send that into the Ontario Association of Designated Officers. They'll e-blast it out to everyone, and then suddenly you can get examples of forms that are used all across the province by emergency services. So it's an excellent resource. They've built a phenomenal manual. It's just under 200 pages. It's updated every 2 years, and it really is a guide to and an excellent resource for anybody working as a designated officer. It is part of and it's actually part of, if you take the designated officer course through Public Services Health and Safety Association, it is part of your package. You receive it as a resource. Now, the Ontario Association of Designated Officers has recently merged with the Ontario Hazardous Materials Responders Association, and it's basically two organizations that are run by volunteers with vast experience in emergency situations, pre-hospital care on the care side, and emergency response in general, uh, coming together and sharing a website and just sort of being able to support each other. So it's a good thing. So an infectious disease side, and then there's the hazardous materials side, but they've joined together as an organization. If you take the Public Services Health and Safety Association Designated Officer Program, you actually receive a 1 year membership with with your with your program with the Ontario Association of Designated Officers. There's also IPAC Canada, Infection Prevention and Control, and this is just an organization, primarily people from healthcare. So in hospitals and complex care and uh, all the different aspects of healthcare, where their association for infectious disease practices and protocols. So excellent resource, their website, lots of information there, as well as the CDC in the United States. Fantastic resource, and they have some great fast fact sheets. And when I worked as a designated officer, I often would use that because you'd go out and speak to people, and I did have a few times where they kind of looked at me sideways and said, I'm pretty sure you're not a doctor, and I'm like, you're right, but here's the fast fact information. And quite frankly, at the end of the assessment, if you want to be seen by a doctor, let's go see a doctor. And that's usually the direction we went when if that was the discussion. We also have the public health agencies. We've talked about our public health um, or local public health units. They usually have a lot of great fast fact information, as well as the overarching Ontario, Public Health Ontario. Lots of great information there, including PPE. They've got a directive on emergency services and what PPE to use for what um, situation you're in. So definitely something you might want to have a look at. And then the Public Health Agency of Canada, which is that national look. What are the trends? What's trending across the nation? And they also are connected internationally. So what's going on internationally and very much on people's minds these days. Now, an interesting thing happened after SARS. Um, the province sort of sat back and said, okay, well, what was missing during SARS? And a whole infection prevention and control best practices documents. That's what was kind of missing. So what the province did was they brought together all the people who worked in infection control, sort of the top names in all the different hospitals, and they wrote a best practices documents. And these are all free downloads off the internet. The one in the top left-hand corners is definitely one you might want to give a quick download to. Routine practices and additional precautions. This speaks to when to wear a mask, when to wear an N95 mask versus a procedure mask or a surgical mask, um, when to wear a gown, when is a shield appropriate, and as I said, a free download. off the website, and I think they're on the third edition at this point. But they're continuously being updated. Other ones, cleaning, disinfecting, and sterilization is another good one, and hand hygiene. These are all they're all part of they're a fit for what's going on in the province right now. So those are some examples of resources and the importance of having that designated officer, some resources to back that designated officer up, telling you about who in the province is there to support you, and they are directed by a provincial mandate to provide that service and support back to you. So make contact with them, and so they know who you are. There's no question they're busy right now. And don't forget, it isn't just the current situation we're in with COVID-19. There's still a number of other things that are out there, potential exposures for all of our workers. So thank you very much for listening.
Well, thank you very much, Tim. Certainly, COVID-19 has impacted the role of the designated officer, and your presentation has provided some great information for those attending the session this afternoon. We can open up the chat line if any of the attendees have any questions for Tim. He would be happy to take those at this time. Okay, at this time, Tim, I don't see any specific questions coming through the chat line, but just one question, listening to the presentation and wondering, from a designated officer perspective, has COVID increased a lot through our emergency services sectors as far as what you're hearing through your stakeholder groups, Tim?
Has it affected them?
No, have we seen
Absolutely.
a dramatic increase with the designated officer role specific to COVID through the province?
Oh, testing
Yeah.
positive of workers. Yes, there have been some workers who have tested positive, and there are some organizations where if somebody, when they do test positive, they automatically go off for 14 days. Some have within their collective agreement that that is automatically paid and taken care of, so that's a good thing.
Good.
Others are allowing it to either proceed through WSIB or sick time, depending on the organization. But yes, there have been absolutely have been cases. Now, the difference between COVID-19 and SARS is that SARS was in the hospitals and it didn't get out of the hospital. So basically, if you acquired SARS, you either were traveling to Hong Kong or other areas in the world where it was, or you were in one of the hospitals. Um, COVID-19 is that bus left a long time ago. We have community spread, so people can contract not only in the workplace, but they can also contract when they're shopping at the grocery store or getting gasoline or that sort of thing. So there are other opportunities, which is why we're being directed by the Chief Medical Officer of Ontario to all wear masks when we're outside of our bubble, outside of our little group, and doing things like shopping and the like.
Thank you. I see a question in the chat, Tim. VSA calls are automatically labeled COVID positive. Does the hospital or coroner test for that post-mortem? Do you know?
Yes, yes. And then that would then be part of that contact you would receive from public health, um, depending on the type of exposure that could happen. So they are and this is why it's so important to have that connection with your public health unit, so that your name and phone numbers kind of on their mind. And I used to say on their ink blotter, and I don't know anybody's that actually people have moved home, so if it's on their ink blotter it's not going to help you, but that they are aware of you and will give you make contact with you.
Excellent. Thank you, Tim.
Okay.
I don't see any other chats coming in at this time. I'm just going to check here. So once again, thank you, Tim, for sharing your imparting your information, and very timely on designated officer, particularly with COVID-19 entering into that role as well into the workplace. So thank you for the attendees for coming to the session. And I would like to remind you that there is a virtual conference evaluation that we would ask you to complete at end of day today, if you would, for us, please. And you can also go back to the main stage and listen to closing remarks. And then that will conclude our Return to the Workplace virtual conference today. So thanks again, Tim, and thank you for the attendees this afternoon.
Thanks very much, everyone.